Good evening, everyone. With another session with Virtual Global Spine Conference. Tonight we have a special guest, a friend of mine. He's also my partner, Dr. Alpesh Patel. He's the co-director of the Northwestern Center for Spine Health. He's the professor of orthopedic and neurosurgery at Northwestern Medicine. He's also the fellowship director. And it's really an honor to have him here to share his thoughts about cervical spine decision-making or decision-making during cervical spine surgery and when we're treating patients with complex spinal disorders. Alpesh, thank you for joining us and for accepting the invite. The floor is yours.
Honor, my friend. Thank you very much for having me. And I want to thank everyone for their time tonight. It's really a pleasure to be here and to speak with everyone as best we can, right, in this virtual world that we're living in. And as Nader mentioned, what I'm hoping to talk about as we go through these cases are some of the common traps in decision-making. And I'll get started on the cases in just a minute, but bear with me. I've got a few maybe bits of background that I think might help us in the discussion as we move along. So these are my disclosures. Nothing is directly related to anything we're going to talk about. There may very well be products that pop up during the cases or in the x-rays that I may have a role in. If it's relevant, I'll try to disclose it, but I will tell you that's not the focus of our conversation today. I do want to take just a quick moment and just again express my enthusiasm for being here tonight. I think this is a pretty remarkable effort that's been launched in the last 12 months. And I want to take a pause for a moment and just give a round of applause to the organizers who put this together. It's really been a joy for me to be able to watch come up. I think it's a great example of innovation and ingenuity in the face of adversity. And I think it's a great lesson that we can all learn from. And I can't wait to see where this goes in the years to come. So just a quick pause and a congratulations to everyone whose idea this was. It's been wonderful. With that, what I sort of want to do in this discussion tonight is take a bit of a deep dive and talk a little bit about decision-making. And this has become more and more of an interest to me as I think about how we lead and manage groups of surgeons and large teams of surgeons, is understanding decision-making. And oftentimes, our conversations around decision-making start with the what, right? And I think we'll go through that tonight. We'll show some cases and we'll talk about what would you do in this situation? What does the audience feel like we should do? And that's really obviously very important. It's the actual act of delivering care. But I'm going to argue that we can go a little deeper. And we want to start to talk about the why we do things the way we do. And that's tough to do. It's easier to do in one-on-one conversations. But I think platforms like this are a great way to start to talk about the why we make decisions. But really, to get to the why, I think we need to understand how. And that's a bit of what I want to talk about for maybe just the next 2 to 3 minutes before we start on cases, is to give some thoughts I've had and I've pieced together between my experience as a surgeon, my time in my MBA education, and then sort of leading our venture at Northwestern, is understanding how we as surgeons make decisions. And maybe today we'll leave with a little bit of insight on that. So does that work for everyone? If that works, could I just get a quick thumbs up or a nod of the head or there we go. Some interaction with the outside world. I love it, because otherwise I'm just staring at a black box here. So, so thanks for that. So let's keep moving. So I think there's then going to be 3 keys that we want to take away, and I'll circle back to these at the end. But there's 3 things I want you to take away in this deep dive as we dive down towards understanding how we make decisions. One is that we're going to start off by accepting that we're all human beings. I'm talking to a room full of really accomplished people, super accomplished people. It's going to be hard to convince you that you're a human being, but I'm going to do my best. Second is that we want to reflect on what are the common biases in decision-making. I think we skim on this a little bit in our training, but we really want to go deeper. And then what I want you to leave with, like, what can you do tomorrow, is I want you to take some of the bits of what we talk about and hopefully challenge yourself, challenge your own thinking, and think about how you improve the people and the processes around you, knowing what you'll hopefully leave knowing tonight. So let's start on that first element, this notion that we're human beings. Again, we are all well-accomplished physicians and surgeons, and We all have different backgrounds, but some similarities are that we've all worked really, really hard to get where we are, right? We've studied harder than anybody else. We have outperformed, probably peers when it comes to things like standardized tests. We've interviewed and applied and interviewed and applied and interviewed and applied for residencies and jobs and fellowships and you name it, right? And so we like to think of ourselves as a cut above, right? We like to think of ourselves as a different breed. And I think what we understand as we dig into decision-making is that unfortunately we're not. We're still human beings. We're still governed by the same rules that every human being is governed by. And if you are familiar with this book, I'm going to give it the orthopedic surgeon's take on it, which is going to be very simplified. But it's this notion that our brains work in certain ways. And I would strongly recommend this as a great, not short, but a great read for folks who want to dig into this a little bit deeper. But the idea is that our brains are structured in certain ways. And that structure of both fast thinking and slow thinking has a real impact on how we make decisions. And this is true both in medicine and not in medicine, right? Just in our daily lives. But it becomes crucially relevant as we make surgical decisions. So what does that mean? It means that we oftentimes tend to divert towards simplistic or heuristic thinking, right? We tend to think about mental shortcuts in our decision making. And that's a lot of what I hope we talk about tonight. This is just a nice summary. There's way too much to take in at once. Feel free to screenshot it if you want, or if you Google, cognitive bias codex, you'll be able to find this similar slide to give you some framework around what are the biases that are at play. But biases come into play, they show up, if you will, under pressure. And that pressure can come in different formats. It could be time pressure, it could be an informational pressure, where either too much information on the one hand or not enough information on the other hand. Settings of uncertainty, when we don't know exactly how things are going to turn out or shake out. Situations where there's really, really big impact, big consequences on the decisions we make, right? And then in situations of risk, when things are really, really risky for the decision maker themselves. And I would argue that this is just every day for most of us, right? This is walking into clinic for me on a Tuesday, or walking into the OR on a Monday. This is just life as a surgeon and as a physician. So understand that these pressures that we live under, that we've normalized, are not normal, and they do tend to trigger these responses in our minds at times. So we've gotten to this point now, right? We know from really good science, Nobel Prize winning science, that bias pressures can influence how humans make decisions. And I think we accept the notion that these are also going to influence how surgeons make decisions. They can't not have an impact on how we think and how we make decisions. So I mentioned we're going to take these deep dives, but we also have to then come up for air periodically, or this becomes really dry really fast, right? So this is one of those moments where we're going to come up for air. We're going to talk about a case. It's going to be one of 3 cases that I'm really excited to share with you. All these cases are mine, and they're all cases that even years later I've taken away a lot from and tried to reflect on and learn from. So what I'm going to do is show a case, and then I'll pass the mic over to Dr. Daudelet to maybe moderate a little conversation amongst the panelists, and then maybe gauge some audience feedback. But this was a 44-year-old female patient who had come to me with neck pain, pretty severe neck pain, posterior-based neck pain, movement-related neck pain, and then also having some symptoms of radicular pain down the arm, left arm, and then some tingling numbness into her thumb and index finger. So Nader, do you want to pause on the X-ray? Do you want to go on to the other imaging? What do you want to do?
Sure. Yeah, we can pause on the X-ray really quick. Dr. Gibbs, what's your take on this X-ray? The lateral view, then the AP view.
Well, from that description of the symptoms, I was kind of surprised. It doesn't look too bad on the X-rays. I mean, maybe some mild disc space height loss, but from the X-rays, we can't really tell too much. I bet your MRI will be much more impressive.
I agree. I mean, it looks like there's a little degenerative disc disease at 5, 6, 6, 7, maybe a little small osteophytes down there. Sure thing. Yeah, but there's no subluxation. We can surely move on to the MRI or whatever the next study is.
Yep. I will say the one part I'll point out is I actually now am taking as much away from the AP film as I do from the lateral film. And if I look at the AP film, I'm looking at, the unguents quite a bit. and looking at uncinate hypertrophy, loss of space between the uncinate. And so you can make that out. I'm not sure if my mouse is showing up, but really nicely here and here. And I'm thinking, okay, maybe this is a sign of that we're going to identify some foraminal narrowing that maybe might be a little underestimated otherwise on the X-ray. So this is the MRI, and I'm just, for the sake of brevity, showing a few cuts as opposed to the whole picture.
Okay, again, we go back to our radiologist, Dr. Gibbs.
Yeah, again, I mean, I look at so many of these every day, and this is probably one of the better ones that I would see. It does not look as bad as the symptoms that you described. You know, get maybe a left-sided kind of a disc herniation there on the left, narrowing the foramen at 2, 3, 4, 5, 6, maybe 6, 7. Is that bottom slice?
Yeah.
The cut above, that doesn't look that bad.
Yeah.
Yeah.
To me.
Yeah,
relatively.
I mean,
no cord signal that I can see. Good canal, good CSF. No cord compression. That's all I've got.
Yep, I totally agree. Dr. Baj, what do you think? Anything you want to add? Anything?
Yeah, I think I agree with that. It looks like there's some spondylosis there at C5, 6, C6, 7, probably some mild bilateral stenosis at 5, 6. On the left side, you know, if there's concordance with the symptoms, the stenosis in that left foramen at C6, 7 probably looks a little more impressive than at the C5, 6 level. So you know, if the patient has radiculopathy, that's attributed to the, you know, C7 root, that may be the causative etiology there.
Yeah, I totally agree. I mean, I think at our institution, they would read maybe C5, 6 as moderate foraminal stenosis, probably an overread, and then moderate to severe at 6, 7 on the left side. Yeah, I think we're on the same page. One of the, on the chat box says loss of cervical lordosis. Well, you know, usually we assess lordosis or kyphosis better on an X-ray upright film as opposed to on a supine film like an MRI. So, but good point was pointed out by one of the participants.
Just so to see the X-ray. Yep, great point.
Okay, let's continue, I think.
All right, so we're on the next step. Let's make an assumption that this is an individual who's had appropriate conservative management. What do we think about treatment if they're coming to us for a surgical opinion? It looks like Dr. Gibbs wants to step in.
No, I was going to say I'll do it. I'd give him a nerve root block for you to make sure that's the level.
Yep. So,
or is that part of conservative?
You jumped one step ahead of me, but
okay.
I love it. So yeah, I was thinking to Ali's point, you know, this is an individual who had radicular symptoms, some numbness in the thumb. Where could this be coming from? So we tried a selective block first at 6, 7 in hopes that would solve most of the trouble. It didn't. It only resolved some of her symptoms. So we did 5, 6, which resolved a little bit more of her symptoms. But then the symptoms kept recurring despite the block.
Okay, let's ask our colleagues here. Dr. Galgano, for instance, what would you offer this patient, for instance? There are many different options. She maximized non-surgical treatment, and, you know, is it, you want to offer her an ACDF, an arthroplasty, 1 or 2 levels? You want to offer a foraminotomy? How would you, what's your thought process? The patient is, how old is the patient again? She's
34.
Yeah, younger patient.
Did you say that she has any weakness, or is this just as all C6, 7 radiculopathic symptoms?
So she has neck pain and left arm pain, and then the numbness in her thumb. No weakness on exam.
Doing an arthroplasty, if one of the primary complaints is neck pain, I'd probably veer away from doing an arthroplasty. I think it looks enticing if she just had a radiculopathy, but with neck pain, I'd be worried that some hypermobility, she might have some more neck pain afterwards. So I think either doing a single level ACD in this particular instance, if the block proved that this was in fact the culprit foramen, I think doing a single level ACD at 6, 7 is reasonable, or doing a foraminotomy. In my practice, I tend to do ACDFs more for something like that. I think either way is, I don't think you go wrong either way though.
Excellent. Okay, Dr. Patani, let's ask Dr. Goodwin, what would you do in this for this patient, for instance, if he's with us?
think he might be on mute.
On mute. Okay, Dr. Rassouli.
Yeah, so for this patient, she's young. She has signs and symptoms that are concordant with that C6-7 left paracentral osteophyte or disc. And it sounded like she got temporarily better with an injection. So in my practice, I would offer this patient a one-level posterior cervical foraminotomy. I would just avoid fusing her or doing arthroplasty altogether.
Mm-hmm.
Okay, I'm gonna, for the sake of time, I'm gonna go ahead and move on then, Nader, because I think all great opinions, and that's absolutely where my head was at, and bouncing around the ideas behind ACDF versus TDR versus just a decompression. This is where my brain was focused. And then like Dr. Galgano had said, I tend to, and these folks, my tendency is to hedge towards an ACDF. So this is my immediate post-op x-ray. Immediately afterwards, when I used to put drains in, and I used to keep them all overnight all the time. I used to use allograft. So this is all an older case of mine, but nonetheless, this is sort of a pretty standard post-surgical view. And then this is, sorry, I'll pause here. This is 5 months later. She's coming in to see me with fairly severe neck pain. Her neck pain actually never got better, only got worse post-operatively. It only continued to get worse. Her arm symptoms came and went, but by this 5 month mark, they were also maybe getting a little bit worse.
Okay, so I'm gonna ask Dr. Goodwin. So what do you think?
Hey, sorry. So I was I'm able to unmute now. So this is exactly what I would have done, which is probably not the right answer because you're going to show us something else that's happening. But looks like a well done surgery. So everything's kind of the same. Is that right? Am I hearing you correctly?
Yeah, same or worse. I actually would tell you she's worse.
You think she's a little worse? I'm looking at the, I don't see any obvious movement here. I'm looking at the level above the, I guess some would argue the plate's a little close to the disc space, and we'd worry about that disc maybe breaking down a little faster than the others. 5 months out, the same or the worse, I'd probably get an MR and see where we are.
Yeah, I mean, that's a good point. The thing is, like with these patients, if they get better and they have a honeymoon period, then you'd say, well, I found, I got the pain generator, and if they get better and they have a honeymoon period, then they have new symptoms or recurrence of symptoms. You think of one of two things, either adjacent segment disease or a pseudoarthrosis. But
or that wasn't the problem in the first place.
But the thing is, like, the thing is, like, if they don't get better, then you start worrying, like, is it a misdiagnosis?
Yeah, because I mean, this surgery looks great. And if she feels worse, that maybe that wasn't the original, maybe something else going on.
Exactly.
I wish I had Dr. Gibbs working at my hospital when I took care of this patient, but I'm going to tell you what actually happened, because this is one of those memorable cases for me. I agreed. Like, I was a little worried here. I thought I was being maybe a little hypercritical and saying maybe there's a little bit of motion on flexion and extension at the upper level, right at 5-6. Maybe I'm seeing a little bit of a pseudoarthrosis line in the disc space at 6-7. And I thought, well, this is only 5 months in. It's too soon to call it a pseudo, but maybe this is a delayed union. Maybe this is a construct that's just not strong enough for the patient. And I wasn't so sure about her arm symptoms. I ended up getting a myelogram and a post-myelogram CT on her because I just wasn't convinced I knew everything that was going on. Unfortunately, due to the ravages of time, that CT myelogram is long gone. I could not find it, so I apologize for that. But after the myelogram, she had a really wicked headache, really terrible positional headache. So we sent her back, as the protocol was at our institution at that time, for a blood patch. She did well for about a day and then had a recurrent headache, pretty bad headache. And I think if I remember correctly, she maybe even had a second go at a patch without success. She then had a subarachnoid drain placed, which was maintained, at least my recollection, totally appropriately, and yet had persistent headaches after the drain was removed. This is the only time that so far I've had to take somebody back to actually open them and do a direct repair of a myelogram site. But that's what I had to do. I had to open her, did a laminectomy, and repaired this very clear punctate area of CSF leakage, which left her with, her headaches went away, but then she had fairly substantial and fairly severe back pain. So we're now in the situation where I now have created neck pain. I've got her with persistent arm symptoms, this intermittent numbness. Now I've created back pain for her, which wasn't so much of a problem before she met me. And I'm going to jump one step ahead and say I convinced myself that I had a symptomatic pseudoarthrosis that I was managing.
Alpesh, I apologize. Can I interrupt real quick? Just something, a good learning point for us and some of the participants. So preoperatively, if now in hindsight, so we saw the MRI, we saw the foraminal stenosis on the left. In your you're an extremely accomplished cervical spine surgeon. So when do you utilize EMGs and electrodiagnostics for the cervical spine pathology? Is this such a case? Is it when you're not sure, or can you just share with us your opinion on that? I know it's off topic, but I want to know what you think about EMGs in these cases.
It is not off topic at all. It is spot on in terms of where I'm leading hopefully here, which is this idea of, did we have enough information? So can I circle back to that, Ali? Is that okay? Can I come back in like one slide?
Yeah, not a problem at all. Yep.
Perfect. Dr. Patel, sorry to interrupt you. Did you learn it? Did you already say what the CT myelogram, did it show you anything or no?
Well, it did show me it showed me a non-union at both levels, 5-6 and 6-7.
Okay. Right.
So it did sort of confirm to me that there was a pseudoarthrosis there.
And how long are you waiting before you did this, before you address it?
By the time we fixed this is probably now 6 to 7 months post-operatively, which is on the early side. I typically will try to let a non-union, if you will, declare itself at least about 12 months post-operatively, assuming it's structurally intact. The plate's not loose, the screws aren't loose.
Yeah, okay.
So I usually will wait a little bit longer, but again, the severity of this patient's symptoms sort of, was a pressure point for me in terms of wanting to move faster.
But disc above looked okay, foramen looked okay as far as you could tell, okay.
Above looked okay, foramen looked okay. I was pretty convinced again that I was dealing with a symptomatic pseudoarthrosis. So I took her back, did a posterior revision, fairly straightforward, good fixation, posterolateral fusion, watched her post-operatively. By about the 5 to 6 month mark post-operatively from this procedure, I had a solid anterior fusion and I had a solid posterolateral fusion. But I also had a patient who was no better. Still had terrible neck pain, still had intermittent arm symptoms, and also now had back pain, that I didn't have before. So the takeaway point from this first case is this idea of, and I think Dr. Gibbs was hinting at this, and I think Dr. Faj was hinting at this, is that in hindsight, what might have we had done differently? We clearly didn't get a good outcome. We got a good radiographic outcome, but not a good outcome. And so looking at that sort of before and after analysis, to me, very clearly, this is a situation where I honed in and I zeroed in on those arm symptoms, right? I honed in on the notion that this was a radiculopathy. And I had things to support that. I had the MRI, certainly at 6-7 to support that. I had the response to diagnostic injections, although I think we need to be careful about how we interpret diagnostic injections, because that's open to interpretation, right? And, I had what looked like a case that I enjoy to do, and, generally we get good results from. So I completely underestimated how much neck pain was her primary driver in this conversation. And this comes into a conversation around one of the 3 traps I want to talk about, which is this idea of confirmation bias, right? There were the notion that we will, as human beings, make relatively quick decisions around what we're going to do. And in this sense, what am I going to do as a surgeon for this patient? And then I will tend to, or individuals will tend to look for information that confirms their decision as opposed to challenges their decision. And so that is my takeaway from this case, is the idea that I think, again, from a technical standpoint, I'm, with all the dissection in the world, I can't think again about what I would have done different technically, but I would have absolutely done something very different in my decision-making. And in terms of how to combat this, or how do we work around this idea of confirmation bias, it absolutely starts with the team approach, right? And so getting multiple eyes on a patient prior to surgery, that's a great way to go. And we did a little bit of that tonight, right? We heard some dissenting opinions along the way saying, is this really where the pain's coming from? Are we sure? How do we know for sure, right? Actively seeking disconfirming information. This goes to Ali's point. When do you order other tests, right? And I think it's in these circumstances where you've got maybe a lot of axial neck pain, or even let's say axial low back pain, and you've got inconsistency in your story with regards to the radiculopathy maybe. That's where an EMG might come in handy. But I'll tell you honestly, Ali, I use an EMG mostly to rule out peripheral nerve entrapment, not so much to bank on it to diagnose, you know, cervical radiculopathy. And I certainly don't bank on it to diagnose a level of cervical involvement. I just haven't seen that, you know, that degree of consistency. And probably the most important thing is just taking that pause in the decision-making process. And I feel like this is a situation where if I had just listened a little bit more before I made that initial decision, I might have made a very different one. If I'd really listened to how much neck pain this person was coming in with, I may very well not have offered her anything, let alone a TDR or an ACDF or a foraminotomy. That's my challenge to the audience, and I want to listen to see what you guys think.
I think this is Ali again. I think this was great, but this is a very interactive and sometimes controversial program. So I'm going to put you as our guest on the spot. Do you think ACDF is a good treatment for patients with axial neck pain and spondylosis? In other words, if she told you I had no radiculopathy, just terrible neck pain, I tried everything, she's got, the findings that you showed us, do you think, in your vast experience, is ACDF a good operation for patients with axial neck pain and let's say moderate to severe spondylosis of the cervical spine?
I'm going to say it's a completely inconsistent operation. I'm going to say that there's so much it depends in that answer, right? That as a blanket statement, I don't think it's a good option for axial neck pain. And that is a bit controversial. So I hammer away, but I do not think it is. And I also don't think a TDR is a great option for axial neck pain, right? I think it comes down to maybe making sure we've understood where the pain generator is, because I think a lot of times we make assumptions on pain generators. And sometimes as surgeons accepting the notion that we can't fix everyone. So I would say no.
Yeah, that's really interesting. I mean, I've done hundreds of ACDFs, and usually the indication is either radiculopathy, myelopathy, or both. For axial neck pain that's purely axial, I've done one. I remember that. I've done one, and a patient who's had neck pain for 10 years. He's an engineer, pretty reliable patient. He had significant spondylosis at 5, 6, 6, 7, like bone on bone, really arthritic. And I kind of went back and forth with him, told him, this is a 50-50 operation, and not super, enthusiastic, but let's just do it. We did it. His neck pain went away, and he sent me Christmas cards. But that's one patient out of hundreds that otherwise either myelopathy or myeloradiculopathy. It's, as Dr. Patel said, it's an inconsistent operation when you treat axial neck pain. It's just not as predictable in terms of an outcome, like flipping a coin.
And I want to stress, I'm not saying don't do it. I'm not saying it's wrong. I'm just saying let's accept the notion that this is a pretty inconsistent space we're working in here, right? Unlike managing myelopathy or managing radiculopathy, where we've got better outcomes and better evidence. And so even if you just pause and you ask yourself, is this really going to reliably improve this patient's pain and function, et cetera, and then sharing that level of uncertainty and inconsistency, if you will, with the patient, I think is something that we need to do more of, right? I don't think it's done enough.
Okay, can I ask a question? I know you have to get to another case, I'm sure, but this one's fast because you brought it up about the interpretation of the nerve block results.
Yeah.
I take it did you do it or did your radiologist do the test, the nerve block?
That's done by our radiologist. And we were using a pre and a post-procedure VAS as a way of trying to get some of that bias out of the assessment, right? And you measure a VAS arm pain before, VAS neck pain before, and then the same numbers afterwards.
I'd be interested in seeing all those numbers because there's a difference. I think that, you know, we've discussed before, not everybody knows that if you do an epidural, transfemoral epidural, you're going to help your nerve pain and your neck pain probably more than just the root block.
Yeah.
And I don't know what they do at your institution. At mine, when I got there, they were all doing the epidurals, which to me seems like it would confound your results a bit. It would also travel up and down to multiple levels.
Yeah.
So I was just curious if that's something, part of what you were saying, or maybe you had something else you were talking about.
For exact reasons, I try to do these as selective root injections, and we try to order them as selective root injections so we minimize some of the noise if we're thinking about them from a diagnostic standpoint, for sure.
Which in the cervical spine, I think they always should be. I don't think anybody has ever helped long-term by a cervical transforaminal epidural steroid injection. Maybe in the lumbar they are, but not cervical. I think those should always be diagnostic.
Yeah.
I don't know if everybody else's experience, but I don't think you're going to help anybody for more than a few weeks.
Listen, I love the stance you're taking because I think that's what many of us see clinically. But, you know, there is a whole other world out there that believes in repeated cervical epidurals. And so rather than maybe riling that group up, maybe I'll just keep moving because I think there's a couple more good cases to go over. And I definitely am enjoying the discussion tonight, though.
So this patient, sorry, looks like the case is over. So their arm pain was no better. Am I getting that correct?
They were no better in any way, shape, or form.
And then what happened? You did an EMG at some point, or what happened to them? Or they just?
You know, I'm sure at some point, once I got them solidly united, I probably referred them to our pain management team. You know, once I sort of looked and I said, I cannot, and I have no doubt, this case was a while back, I have no doubt, I'm sure I got follow-up MRI scan to look for adjacent level. That would be pretty much the routine steps like Dr. Donnelly had mentioned of thinking about patients who are having persisting symptoms. But this is a case that, for me at least, has been a stark reminder about, you know, being really cautious about understanding what the symptoms a patient has going in and making sure that you're on the same page with them in terms of, you know, this is a case where I was focused on the arm symptoms and the radiculopathy, and that's clearly a disconnect from where the patient was. All right, so my second case now. So this is going to get a little bit more complex from a standpoint of the actual offending pathology. And maybe, Nader, just because we have about a half an hour left, let's maybe try to get 2 or 3 comments, and then I'll try to keep moving along because the last case is a doozy, and I want to make sure I get to that one.
Okay, so this looks like a trauma case, and you know, mid-sagittal in the middle, and then parasagittals on both sides, right and left. Dr. Gibbs, you want to make a quick comment on this?
Oh yeah, just quickly. I mean, you've got all columns involved here, whichever system you use. So you got facet fractures on both sides. It looks like you got spinous process. You got anterior wedge and split on that, whatever, 2, 3, 4, 5, 6, 7. I mean, to me that, and then you have C3 as well. You got a bunch of levels of injury here. What was, fell off the bed? That doesn't seem likely to me, but to have this extensive of an injury, unless you have some other underlying bone pathology that would make you very brittle. And I've never seen anybody with an injury like this that wasn't in like a motorcycle or a motor vehicle, but
and this was
certainly you would get an MRI.
My involvement on this patient, I began a number of months after his injury. So I had gone back to try to track as much of the imaging as I can. So but the story is pretty consistent that this is an older gentleman, fell off the edge of his bed. I didn't ask him how tall his bed was, but maybe it's what I'm imagining. But he did strike his head. And he actually, in addition to this, had pretty severe pulmonary contusions. He had some baseline COPD. We didn't talk about that yet, but he had really sick lungs to begin with. And so, you know, at the time of his original injury, he was actually intubated and maintained intubated for quite a while. With regards to his neurological status, when he presented, he was actually neurologically intact. The only sort of complicating factor, again, was the pulmonary issues that he had chronically and ongoing, if you will, or worsened on top of that chronicity. So I agree, totally multi-level injury, multiple column involvement. I'm going to jump ahead a little bit and bear with me because, again, I want to make sure we get to the take-home point of the case. So he was treated surgically, and I'm going to get to a pause where we can talk about what you would do next. But he was treated surgically by another surgeon, had a posterior-based procedure done, maintained, stayed intact, stayed neurologically intact. But this is his post-surgical construct. And maybe I'll pause here and maybe get some thoughts from the group on.
Yeah, I want to know, Nader, why did you do this?
Not Nader. This is not
Nader, come on.
So first of all, that's yeah. I mean, the first question is okay. You know, so there's no doubts about it that the C6-7 flexion distraction injury, or if you want to call it a teardrop with posterior element disruption, is unstable. Surely is unstable. But the other question is the injury at C3, C3-4. That may have been an unstable injury up there. If we go back to the CT scan, you know, it may be subtle, but that C3 injury, to me, it may be unstable. Like, you know, so I'll be careful. So the caudal injury, there's no doubts about it's unstable. The cranial one, I think it's unstable too. So to me, I would have treated differently. I would have probably went to C2 to T2 posterior, or maybe a C7 corpectomy, then a C2 to T2. I mean, you know, I like to reconstruct the anterior column, but if you're doing a long posterior long segment, that should be sufficient. So that's my only comment. You know, you don't want to miss on an unstable subtle injury. The caudal one is no doubts about it. The cranial one, I think, you know, there's some posterior element disruption there, and maybe the interspinous, supraspinous leg flap are disrupted. So that may be unstable. And you don't want to also stop your construct short of a fractured level too. So these are my comments.
Yeah. And the other component, I would echo those concerns. And this is not Nader's case, just for the record. It's not. But you know, the concerns that Nader voiced were concerns of mine. I also am concerned about how great, you know, lateral mass fixation is, right? Especially in a potential junctional zone. Let alone if, like most techniques nowadays, people are doing them as unicortical, right? Lateral mass screws instead of bicortical lateral mass screws. So this is his immediate post-op, and then eventually the patient is you know, decides he wants to transfer his care to us. I'll also just point out that he ended up actually with a tracheostomy because of how bad his pulmonary issues were. You can kind of make that out on the image there. So he comes to me then. This is where he's at. This is, I think, now about 4 months post-operatively.
Yeah, can I just ask, because Nader just said this, I thought whenever you had an injury like that in the anterior column that you would have to stabilize that. I know, Nader, you just said that if your construct is long enough, you might not have to, but I just assumed it would fail, either break or pull out, depending on what, you know, whichever went first. And especially with a person like this, it seems like, I bet they have poor bone quality if they're that sick in general. Would you have, and you said you might have done something else, right? Not, or is that?
Yeah, I would have gone C2 to T2, plus or minus doing a C7 corpectomy. My threshold is low especially on the cervical spine, with a burst fracture or a teardrop fracture to do a corpectomy.
So I think you're all spot on. I think you're spot on in the sense of anterior column being an issue here at the bottom level. And I think, you know, Nader had pointed out the concerns at the top level also potentially about stopping in a potentially unstable zone. And so again, I think many of us would maybe look at this in hindsight and say, it's sort of an obvious failure mechanism, right? It goes into kyphosis at the fracture level because you don't have anterior column support. You lose proximal fixation because your proximal fixation is only so good. And on top of that, you may have this injury, right? So you look at this and you can say, yeah, I mean, yeah, absolutely. I can see that not working or, you know, failing. By this point, his, I believe his tracheostomy was gone. And so, you know, that was not a direct part of the equation. But this is the patient now sitting in front of you. This is his CT. Nader, do you want to have someone chime in and just give us a quick interpretation of what they're saying here?
Alex Malgani, what do you think, Alex?
Yes, this is a great case. I think perhaps you have to remind that he received tracheostomy. I don't know how the wound looked like, but often this is the reason why the surgeon refuses to go anterior after posterior fixation. And now you see maybe the massa lateralis screws have not been bicortical. It's just a loss of stability. It's a laminectomy. There are so many points I can find on this CAT scan where I can very fine analyze why this construct has failed. But on the other hand, he was severely injured, tracheostomy. Maybe there have been good reasons for the previous surgical team not to go anterior, but I think now we have to go anterior and posterior again, revision surgery from the front, from the back. And I think what Nada mentioned, doing the first surgery as stable as possible, maximized stabilization is the best option you can do. This is the get it right first try. Maybe we could have had prevented this failure. And it's worth to spend some more hour, 2 more hours maybe, for the biggest constructs possible from the posterior in the beginning. And now you have to do it in the front, from the front and from the back, I guess.
Alex, sorry to interrupt real quick. Alex, just a quick question. It's like midnight over there in Switzerland right now.
Yes.
Is that your night gear, or are you in the hospital? What's going on?
Yeah, sometimes the patients try to annoy me. Tomorrow is my son's birthday. I have to work a little bit longer today.
Oh my, yeah. Hopefully we'll get you some rest and you can enjoy your son's birthday. Happy birthday to him.
It shows you how dedicated our panelists are. Thank you, Alex.
I know, it's stunning. It's stunning. So I think gosh, the points that have been brought up are absolutely the ones to tack in on in terms of, why might this not have worked? What we have done differently from the index, right? So in terms of solving this problem, maybe Alex, I'll ask you, what would you try to tackle from a surgical reconstruction at this point?
I think I would definitely go from T2. I will add another level below to really make it stable from posterior. I would do isthmic screw in C2, master lateralis in C3. And then I have to look what is the bones quality in C4, C5 after this pull out, after this failure. If you can do some rescue screws, it's okay. And then I will turn the patient and I would go from anterior. I think there's no fusion. It's a deformity, but I think maybe we are lucky and there's no fusion and we don't have to do osteotomy. And then I would do corpectomy. And I guess I would do some disc replacements as well in a long plate.
So a fairly extensive front and back reconstruction, maximizing stability, correct?
Yes.
Okay. I'm gonna, again, we're at about 20 minutes left. I wanna make sure we keep moving here. And I appreciate your insights, and I didn't do any of that. I did some of it, but not all of it. The constructs at 4, 5, and 6, the lateral masses were completely not competent for fixation. We extended up to 2, added C3 fixation, upsized the screws distally, added fixation into 7 as well, with good 7 pedicle screws, and then dropped a 3rd rod early on. This is one of the earlier cases where I had instituted, a 3rd rod. And you can probably make out all of a sudden now his tracheostomy tube is back. And that was the nature of his airway, if you will. He had a terrible airway and ended up needing a revision tracheostomy in order to obtain and maintain an airway perioperatively. And I'd like to say that's the reason I didn't go anterior, but it's not. It's not. I just wanted to try to address this posture only. So let me get to some of the thoughts I have on this case, because the thought level that we've talked about tonight is the exact kind of thought level I wish I had in my head in real time while this case was going on. And this was also early in my career when I didn't have as many voices to lean on, if you will, right? So my solutions here, as I look backwards in time, were very reflexive answers. Now, luckily I got away. This gentleman went on to fuse, maintained stability, that kyphotic deformity didn't progress. I think we have most recent follow-up was about 4 years out and he's solidly united, right? So I'm very happy with the outcome, but I'm not thrilled with my decision-making in hindsight. My answers were very reflexive. So I looked at, and I've done multiple revision posterior cervicals, as Nader mentioned, extending up to C2 and extending distally. They almost become sort of quick answers, right? They become reflexive answers that we think about in the setting of revision. but I did not address his anterior column. He also had posterior subluxation. I didn't show it. We didn't talk about it in the CT, but there at 6'7", he was subluxed and he actually was ankylosed a bit in that position. I could have taken it down. I could have done the osteotomies. I could have corrected him, and I didn't. And again, with hindsight, I asked myself these questions. Why did I not do more? I got lucky that this healed, but I don't think that justifies the fact that I think my decision-making could have been better. So what this highlights, what I want to focus on here is this conversation around availability bias. That as we make these complex decisions, especially when we're faced with a lot of information in real time, our minds will tend to grab on to the most available information or the most readily available information or the most recent information. As I mentioned, I've done a lot of posterior cervical revisions. I've taken a lot of people up to C2. I'm very comfortable with my multiple, C2 fixation points, pedicles, laminar screws, and the combination thereof. And I think because of that, I didn't really spend the time and effort to think through all the different options I may have had available to me, okay? So how do we work around this idea that our brains will tend to go for easy information or maybe go towards easy or available solutions? One is a post-mortem analysis. If you're not familiar with that, not the actual patient post-mortem analysis, but in the business world, as you're thinking about a project or a program, you think about how is this potentially going to fail? And before you actually even start. So you almost start with a failure analysis and then you work backwards. So in real time, you can create solutions. So thinking about more complex cases in a how might this fail mode nowadays helps me think about how I tackle it early on. I think you have to examine your assumptions, right? I made the similar assumptions. Oh, it's not healed. It's going to move. It'll be fine. Again, I got away with it, but I'm not sure my assumptions were correct. And then remember, each case, especially these complex cases, are going to bring with them a unique set of facts. And spending the time like we did tonight to actually think through those facts is going to be absolutely important. And these are some strategies I'm now trying to do on a regular basis, with my surgical practice. Let's pause for a couple of minutes and get some feedback on some of these notions or some of these ideas.
I mean, these are excellent ideas here, Alpesh. But sometimes you gotta, like we said, okay, we gotta give the patient the best biomechanically sound construct up front. Well, that's easily said than done sometimes, number one. Number two, you always weigh risks and benefits. Sometimes doing more, exposes patients to risks, and you just want to do, enough. That's where the art of surgery comes into play. You have the science part, you have the art part, and you gotta always treat patients individually and factor into their comorbidities and what you can and what you shouldn't do. I mean, but surely, I mean, you talk about like reflexive patient comes in emergently in an emergent fashion, and you want to reflexively do the right thing right away and be maximally aggressive, but hurting the patient also is, you want to avoid doing that.
And that's the exact point. The point of it is that we want to move away from reflexive answers. So I think as surgeons, as we're thinking about these complicated scenarios, if the answer comes to us really quickly, don't anchor in on that. Don't get your mind set in stone on that immediate response or that immediate thought process you have. And really maybe spend the time, which I know there's time pressures, but even in the setting of trauma, you've got time, right? To spend a few minutes thinking about this and bouncing ideas off of other people. Really, really important steps.
Yeah, but one more thing. I mean, heuristics and biases are they're not bad all the time. They're not bad all the time, and we use them on daily basis. But you need to know when to pause, and that's where the art of this comes into play. But I mean, heuristics is not usually, and like biases. When you say biased, it's associated with like a negative connotation. It's not always negative. That's my other comment too.
Yeah, no, and that's fair. But I think the idea of pausing and thinking about it is the important part, because I think many of us, when we look at cases that don't go well, we wonder what were they thinking.
Yeah.
right? Or what was I thinking? And the notion might be that, you know, we were maybe relying too much on those heuristics, right? On those shortcuts. So let me ask you guys, it's about 5:50. This last case is a bit of a doozy. I can go through the case pretty quickly, or we can talk about decision-making. Is that okay?
Let's go through the case pretty quickly and, you know, learn something.
And I apologize because there's a lot to talk about in the case itself, but I do want to get to the punchline. So, and keep everyone's time in mind and let poor Alex get to bed at some point here tonight. So this is my third case. So this was believe it or not, this was my very first case at Northwestern when I joined here about 8 years ago. And this was a retired physician, 83-year-old gentleman. He had had a number of prior thoracolumbar fusions and sort of had gone through this marching process, right? Of marching from a lumbar deformity to a TL deformity to a cervical thoracic deformity. At some point, he had a prior fusion for up to C2, and then was having pain, so his hardware was removed. And then he presented to me because of progressive, 3 to 4 years of progressive deformity, losing the ability to maintain gaze. And these are his upright films. And then I also have a supine film to show. And maybe the summary point I'll take away from this is that this is a rigid deformity, right? Which is not a flexible deformity, it's a rigid deformity. And I'll maybe spend the next minute going through these CTs and the MRIs. And then maybe if anyone wants to pause, jump in and I'll stop and, you know, add in your comments, but then I'll get to the decision-making process. So this is the MRI we had on him. He was neurologically intact, you know, despite everything he's been through, he was completely intact, but fairly severe neck pain and this progressive deformity. So this was his MRI scan, you know, again, demonstrating overall what I thought was that kyphotic deformity, the cords draped along the front, but I wasn't identifying any areas of ongoing, you know, focal cord compression, and certainly didn't have any myelopathic symptoms. This is a coned-in CT, which is showing, I think, his prior fusion. I don't know why one screw was left behind, so hopefully no one asked me that question. I still, to this date, don't know why, but that's his prior post-dural fusion, dorsally coming across, involving the dorsal elements, the facets. And overall, I had some questions around, was this really a solid union at the surgical site or, you know, throughout the course of the surgical site? Probably not. But at the same point, he's still demonstrating, at least on the images, a fair amount of posterolateral bone, right? But we know that folks with deformity can progressively deteriorate or deform over time. These are the CT images. I'll scroll through one more time for everyone. So we went through our routine stuff, which again, remember I was new to the institution, but I had done these procedures before. Routine pre-op medical consult, extensive equipment planning with our surgical team. We had a really extensive anesthesia consult. We had an ENT consult. We had plastics on board. We went through all the routine steps that we take for these really big, complex cases so that we can execute them like we do, like we always do, right? To the best of our abilities. I ended up, oh. Yeah.
Okay, Alpesh, I just wanted to ask a question. Okay, no problem. Keep going.
No. I'm going to come to this. I'll leave my embarrassment on the screen for everyone to look at. But what were you going to mention, Nader?
Nothing. I just wanted to ask Ali, what would you do? But I think you would agree with the T1 PSO. But interesting, you stopped at the occiput. Okay, good. So
this was a case that I remember for a bunch of reasons. Number one, again, from a surgical planning standpoint, I thought we had our plans in place. We had our steps in place. We had everybody on board, called in all the consults that we needed. And medically, we took great care of the patient, I thought, right? I'm going to criticize myself in one setting, which is to say we did a PSO at T1, but I think I undercorrected him. You know, I think I got a fair amount of some correction out of kyphus and at least maybe towards less kyphus. But I do think I got a lot of the correction by just extending him high up, right? O to C2 is maybe where I got more of my correction than I did at the site of osteotomy. And so I took away one point from this case, which was, you know, I've done a lot of osteotomies for ankylosing spondylitis, and I've done a lot of osteotomies for other types of deformities. This unique subset of the multiple revised patient with a progressive deformity it's a different animal in terms of the amount of correction that you likely need. And I think in hindsight now, I would be thinking about a more aggressive osteotomy and maybe even thinking about 1 level or 2 levels and going lower. Because I didn't really assess very much, and we didn't talk too much yet about his thoracic spine, right? He's really flat in his thoracic spine. And so that probably comes into play with maybe why he developed the deformity and maybe why I undercorrected him. But there's even more to the story. It gets even more embarrassing. So post-operatively, he had uncontrollable pain. And when I say uncontrollable pain, I mean uncontrollable pain. Pain I've never seen before, despite having done a lot of really big procedures. And you know, we ultimately called our pain management partners to take a look. And I still remember I got a phone call from our pain management providers, which at least at our institution, it's pretty rare, relatively rare for an attending to call an attending, right? We usually talk through our surgical teams. And it started out with, hey, about or Dr. So-and-so, did you know? And then the real interesting thing came up. He had been on not just pain medicines, but he had been giving himself home Dilaudid, intramuscular Dilaudid at home to manage his pain. And that was one of those conversations where you sit back and you say, wow, you know, again, overall, if I step back and look at this case from my lens, in hindsight, this is a case that I totally underestimated on many levels. I underestimated the severity of the deformity. I underestimated the patient's background and the patient's story with regards to the medications. And so this is the third pitfall, the third trap that I wanted to talk about, and we'll summarize here, is on this idea of the curse of expertise, right? I mentioned we think about routine cases and we think about the routines of a case. And for many of us who do complex work, we get to the point where even complex cases take on a routine. And I'm not saying routines are a bad thing. In many respects, we want to have things be routine. We want consistency and we want frameworks to work under, but we also have to understand that there's a trap in that sense of things being routine. And what that leads to is overconfidence, right? And talking to, again, a room full of, or a webinar full of physicians about overconfidence, you know, can be a bit risky thing to talk about at times. But I think we need to understand that we may very well be in positions where we are falling under this trap or falling into this trap of overconfidence. So just a couple strategies to think about. How do we manage this potential of overconfidence and maybe not thinking things through entirely, or maybe taking off more than you can handle? Obviously, looking at extreme scenarios, right? So look at the extreme scenarios in your surgical practice, the extremely simple and the extremely complex cases, and don't ignore them, right? You got to put some thought into all of them, but then also look for the pluses and the minuses in terms of your decision-making in the simple and in the complex, and challenge your notions on those extremes, right? I think sometimes in a given week, sometimes my hardest case is a microdisc, right? Because it's a common case, we do it all the time. You get there, you get to it, and it doesn't go as smooth as you want. And so I think challenging both ends of the extreme is a really good way to get through this overconfidence. I think questioning one another is really good. I think peer review, Nader will tell you, you know, we have a phenomenal program at our institution where we all look at each other's cases every week, right? And we get insights from everyone every week. And as Nader will also probably tell you, it's pretty humbling at times, right? Because the collective intelligence of the group will pick up on things that you as the surgeon maybe hadn't thought about, or maybe hadn't considered as being as important. So that's one way of trying to keep your confidence, if you will, from being overly confident. Let me summarize them, and then we can open it up just for conversation with the few minutes we have left. So what we hopefully went over tonight, I hope what I was able to convey to everyone was this notion around common pitfalls and maybe some common solutions, right? So we started out talking about, remember, surgical decisions are made by human beings. We're making these decisions. We are prone to the pressures and biases that come into decision-making, just like anyone else. Healthcare in particular, though, probably disposes us towards a lot of these heuristics. To Nader's point, they're not always bad, but they do occur, and we need to be mindful of them. And we need to be accepting of the notion that our decision-making might be influenced by some of these biases. And then that any solution we're going to come up with, at least the best that I can think of, and this is the discussion part of it, any solution is going to have to require, first of all, each of us being aware that this exists, right? That we have these heuristics and these biases at play, despite the fact that we're always doing what's right for patients. We always want to help patients, but these biases are still in the background affecting our decision-making. And then in terms of a solution, once you've accepted that notion that maybe this is a possibility, you got to look for a team-based solution. The more and more I think of this, I don't think this is something that as an individual you can ever overcome yourself, but with a good team around you and good team dynamics, I think you can get great insights and start to ask questions and come up with lines of thought like we've done tonight, but maybe on a more regular basis, maybe in the regular flow of our practice, right? We can find ways to integrate more insights and more eyes on what we're doing and how we're deciding things. So I'll stop there, and then let's leave it open for a few minutes if you can, and take comments or questions.
Absolutely. Dr. Baj, what's your take?
Yeah, thank you so much, Alpesh. You know, just from some of the comments in the chat box, that this is really important stuff. They're really good concepts. They help a lot of surgeons, both young and experienced. But these, what you described today, for me, are what I call the intangibles of surgery, and things that you only learn with time, experience, wisdom. You're not going to read this in a book. You're not going to learn it in training. So they're real concepts that we have to remind ourselves of. And I think this is why it's great to have these, to have you share this with us. I thought it was a very, very inspiring and really very, very informative. So thank you very much. Thank you very much for that.
Ali, I appreciate it. It's my pleasure. And I totally appreciate a lot of this is experience in hindsight. But can I challenge you back? This seems like a group that likes to challenge each other. I will challenge you that these are opportunities, though, that we can pull into how we train surgeons and how we train physicians. I think these concepts that are well-versed outside of healthcare need to maybe be spoken about a little more often inside of healthcare. So I may challenge you back and say, we haven't taught this in the past, and gosh, rather than learning it by trial and error, let's have these conversations with our trainees. So we started a program within our orthopedic department for our residents, focused on sort of surgical leadership. And a big component of surgical leadership is understanding the decision-making process that we go through. So let's all maybe do a little bit better than what was done before, and work on trying to teach this.
Yeah, absolutely. I mean, these things can be taught. I mean, things, even things that we think that are innate, like emotional intelligence, can be improved upon and taught. And then finally, Thinking Fast and Slow. This is a fantastic book, and I read this paper, Judgment Under Uncertainty, Heuristics and Biases. It's an old paper, 1974, and it's the same author. One of the authors authored the book that Dr. Patel spoke about. Kahneman, I think his last name. Tversky, his partner, his collaborator, he wrote the initial paper, Judgment Under Uncertainty, Heuristics and Biases. And that's an important keynote paper that people should read. And, about the limitations of thinking fast. If you have the opportunity or to choose between thinking slow or fast, you got to think slow. All right. Well, thank you so much, Dr. Patel, for this fantastic session on virtual global spine. And then I'm going to let Dr. Gibbs tell us next week's faculty, or is it what do you have
next week. Yeah, thank you. That was such a great talk. That went so fast. I can't believe our hour's up. Next week, we've got one of my colleagues from Mayo Clinic in Arizona, Dr. Mazi Kalani, and he's going to be talking about spine oncology. So the surgery, he's going to be talking about carbon fiber screws. He's going to be talking maybe proton a little bit, which is something we offer to our patients. So that'll be a good session as well.
That's fantastic. Dr. Goodwin will be there. Hopefully Dr. Shin will be there as well to comment. Thank you so much, Dr. Patel. And I'll speak with you offline. This was a fantastic session. Have a good night, everyone.
Thank you again to everyone. Everyone be safe and be healthy out there. And again, kudos for putting these sessions together. They are fantastic. Good night, everyone. Take care.
Good night.